Imagine for a second that you've just been handed a life-saving medical intervention. It's proven, it's powerful, and it genuinely has the potential to fundamentally alter the trajectory of your recovery from a severe illness.
Right, something that could completely change your life.
Exactly. But when you look closely at the bottle, the instruction manual is completely blank.
Oh, wow.
Yeah, I mean, there's no dosage, there's no frequency guidelines, no warning labels telling you what might happen if you take too much. Just a vague note that essentially says, take this, it helps.
Which is terrifying, honestly.
It is. And that is the unsettling reality we are exploring today on the deep dive.
Right.
But the medicine in this bottle, it isn't a pill, it's exercise.
Yeah, and the people holding that blank instruction manual, they happen to be some of the most vulnerable patients in our healthcare system. I mean, when you are recovering from a major physiological trauma like cancer, ambiguity isn't just an inconvenience. It is a profound clinical risk.
It really is. And to understand exactly how we arrived at this point, we are grounding today's deep dive in a really fascinating, highly specific piece of research.
Yeah, it's really crucial paper.
So it's a 2026 systematic scoping review, and the title is Exploring the Fidelity of Resistance Training Interventions in Regional, Rural, and Remote Cancer Care.
Quite a mouthful, but so important.
Yeah, definitely. It was authored by Christopher W. Rowe, Nicolas H. Hart, Julia Carlino, and James Murray. And it was published in the Journal of Sports Science and Medicine.
Which is a great journal. And look, it's a critical piece of scientific literature because it tackles two intersecting crises, really.
Right.
First, there's the fundamental premise that exercise is no longer viewed as just a healthy hobby for cancer patients.
Yeah.
We now recognize it as a critical non-pharmacological medical intervention.
Absolutely.
And second, it tackles the geographical lottery of healthcare. To really grasp why this specific study matters, you have to look at the massive disparities between urban and rural outcomes.
Okay, let's unpack this. Because the gap in cancer outcomes based solely on your zip code is, well, it's staggering.
It really is.
If you live in a rural area, your mortality rate following a cancer diagnosis is significantly higher compared to someone living in a major city. And that's not because rural areas have more aggressive strains of cancer, right?
Not at all. It's driven by systemic disparities in healthcare access. I mean, we're talking about a limited specialist workforce, substantially longer wait times for basic diagnostics, and just huge geographical distances to travel for treatment.
Yeah, the logistics alone are a nightmare.
Exactly. When a patient has to drive 3 hours just to receive chemotherapy, their ability to access evidence-based supplementary therapies like structured exercise programs, it drops to near zero.
Which brings us to the core focus of Rowe and his colleagues' study, which is resistance-based exercise.
Yeah.
And I think a lot of people might wonder, why resistance training specifically? I mean, we hear so much about the benefits of light cardio or like yoga for cancer recovery. But resistance training seems to occupy a very specific, necessary niche here.
It does, and that really comes down to the biological mechanisms of cancer treatment.
Yeah.
Look, chemotherapy and radiation are inherently toxic.
Right.
They save lives, obviously, but they often induce severe side effects like cancer-related fatigue, sarcopenia, which is severe muscle wasting, and negative changes in bone density.
Oh, wow.
Yeah, and resistance training is uniquely powerful because it physically combats those specific side effects.
Mm.
When you lift weights or apply mechanical resistance to the body, you stimulate protein synthesis.
So you're basically forcing the body to rebuild.
Exactly. You are actively forcing the body to rebuild muscle tissue and fortify bone density, which effectively counteracts the physical degradation caused by the treatments. It increases physical function and body composition in a way that, well, like cardio simply cannot achieve on its own.
I always think about prescribing exercise in this context, like prescribing the chemotherapy itself. You wouldn't just hand a patient a bottle of unmarked chemical compounds and say, hey, take some of these when you feel up to it.
No, of course not. You'd lose your license.
Right. The dose, the timing, the specific chemical makeup, it's calibrated precisely to the individual's body weight and blood markers. So why would we treat exercise prescriptions, which induce their own intense physiological stress with any less precision?
What's fascinating here is that the field of exercise oncology actually operates on that exact philosophy.
Oh, really?
Yeah, it is a specialized discipline built on the reality that exercise must be dosed and prescribed with the rigorous exactitude of a pharmaceutical.
Yeah.
The question Rowe and his team wanted to answer was whether that scientific rigor was actually making it into the published research.
Right, like, is the data actually there?
Exactly. Are the studies that rural practitioners rely on actually providing the blueprint for this precision?
And the data they uncovered is pretty sobering, to be honest. They started out by casting a massive net across 5 major academic databases, places like Medline and Sport
The
Discus.
big ones, yeah.
Right. And they were looking specifically for resistance training interventions designed for adult cancer survivors in regional, rural, or remote areas. They started with this massive funnel of 2,490 studies.
That's a huge pool.
It is. And then they rigorously filtered out anything that wasn't strictly looking at this specific population or intervention. Do you know how many studies actually made it to the bottom of that funnel?
It's a shockingly low number.
12. Just 12.
12 eligible studies out of nearly 2,500. I mean, it highlights an astonishing gap in the literature right out of the gate.
It really does. And I want you, the listener, to put yourself in a specific scenario for a second. Imagine you are a healthcare practitioner working in a remote community clinic. You don't have an oncology department down the hall.
Right, you're on your own, basically.
Yeah. You have a cancer survivor sitting in your office dealing with severe muscle atrophy, and they are relying on you to safely prescribe a resistance training program.
A huge responsibility.
Exactly. So you turn to the global academic literature to find a safe, evidence-based protocol to follow, and the entire sum of human knowledge tailored to your specific rural setting consists of just 12 published studies.
And the immense pressure on those 12 studies to provide a flawless, actionable blueprint is exactly why this scoping review was conducted. The researchers needed to analyze what those 12 studies were actually reporting.
Did they actually have the goods?
Right. Were they providing the necessary instructions for that rural practitioner to safely apply the medicine?
And the short answer is no. But to understand why the reporting is so inadequate, we have to look at how the human body actually adapts to exercise.
Yeah, the basic physiology.
The researchers analyzed these studies against the 6 core principles of exercise prescription based on Hoffman's framework. We're talking about the biological laws that dictate whether a patient gets stronger, stagnates, or just, gets injured.
Right. The human body only adapts to physical stress under very specific biological conditions. For instance, the most fundamental law is specificity.
Meaning you have to do the right kind of exercise for the goal.
Exactly. If you want a specific outcome, you have to perform an exercise that targets it. If a patient needs to improve their ability to stand up from a chair after being bedridden, the exercise needs to mimic that movement, like a squat or a leg press. Bicep curls won't help.
That makes sense. And the review found that specificity was actually the most reported principle. It showed up in about 83% of the studies.
Which makes logical sense. I mean, it's the easiest concept to articulate. You're right. We want the patient to get stronger legs, so we programmed leg exercises.
Right, pretty straightforward. But the adherence to biological laws plummets immediately after that. Let's look at overload and progression.
Those two are the engines of physical change. Overload basically means applying a physical stress that is greater than what the body is currently accustomed to.
Lifting more than you're used to.
Yeah, exactly. Because if you don't breach that threshold, the nervous system and the muscle fibers, they have no biological reason to adapt and grow. And then progression is the systematic, gradual increase of that load over time as the body gets stronger, ensuring you continue to provide an overload stimulus safely.
Yet progression was reported in only a third of the studies, and overload in less than 17%.
It's unbelievable.
It is. And even in those rare instances where they were mentioned, the authors rarely justified how they safely achieved that overload. I hear researchers complain about strict journal word limits all the time, right? Using that as the primary excuse for vague methodology.
Oh, constantly.
But honestly, writing down 3 sets of 10 reps at 70% of a patient's 1-rep maximum takes up exactly 1 line of text. Are we letting researchers off the hook too easily by just blaming page limits?
That is a completely fair challenge, and I think we often do let them off the hook. I mean, while word counts are a real constraint in academic publishing, omitting something as fundamental as the progression model isn't just about saving space.
What is it about, then?
It often points to a lack of rigorous, systematic tracking during the clinical trial itself. If a study doesn't rigorously document its initial values, which is the baseline physiological data of the patient before the intervention begins, it destroys our ability to measure the dose-response relationship.
Wait, really?
Yeah, and only a third of these studies reported those initial values.
Let's make that concrete. Because I hear dose response and I think of taking like 2 Tylenol instead of 1 for a severe migraine. If a clinical trial only documents that a patient took Tylenol but never records the milligram dosage, we have no idea what actual amount of medicine cured the headache.
Exactly. That's a perfect analogy.
So how does losing that relationship manifest for a cancer patient doing resistance training?
Well, it creates a critical vulnerability in the science. If we don't establish rigorous baseline data, like the exact starting strength of the patient, and we don't document the exact progressive dose of the exercise over, say, a 12-week program, we cannot scientifically isolate why the patient improved.
Oh, I see.
Did their fatigue decrease because of the specific resistance protocol? Or did they just naturally recover some energy because they finished a grueling cycle of radiation therapy 3 weeks ago?
Right. There are so many confounding variables.
Exactly. Without knowing the exact progressive dose of the mechanical stress, the intervention becomes a black box. A
Yeah.
rural clinician cannot accurately replicate a black box.
And that lack of foundational data naturally leads to the next level of failure at the end of the patient journey. What happens when the trial is over?
Yeah, that's where it gets even more complicated.
The biological principles of reversibility, meaning how quickly you lose strength when you stop exercising and diminished returns, the natural plateau where your body stops adapting to a specific routine, they were reported in exactly one study, a dismal 8.3%.
I mean, to be fair to the researchers, tracking reversibility in diminished returns requires long-term follow-up testing months after the main intervention is concluded.
Which is hard to do.
Very hard. It's expensive and logistically incredibly difficult, especially with rural populations who have to travel far distances just to be tested. But that data is vital.
Why is it so crucial?
Well, a cancer patient might need to abruptly stop their exercise routine due to an unexpected surgery or a sudden drop in their white blood cell count. A rural clinician needs to know exactly how quickly the benefits of the exercise will reverse so they can adjust the patient's care plan.
That makes total sense.
Or figure out the minimum effective dose required just to maintain the current adaptations. Without that data, the clinician is treating a moving target. They have no way of knowing if the exercise dose has become physically toxic or entirely ineffective.
So if the overarching biological theories and long-term data are missing, are researchers at least providing the daily practical instructions? Let's look at the basic recipe of a workout, which is governed by the FITT framework.
Oh, yes. Frequency, intensity, time, and type.
Right. So tell us about that.
It's the absolute minimum standard for prescribing an exercise session. I mean, how many days a week are you doing it? How hard is the exertion? How many minutes does the session last? And what specific modalities are you actually using?
Well, out of our 12 eligible studies, only one single study reported all 4 of those FITT principles. Frequency was the most commonly reported, showing up about 67% of the time, but intensity and time were only documented in half the studies.
That's just not enough information to work with.
No, it's not. And here is the detail that reveals the true depth of the problem. When intensity was reported, researchers frequently used subjective words like moderate. 0 studies explain the objective metric used to determine that intensity.
Which basically renders the instruction almost useless in a clinical setting.
Yeah, what does moderate even mean?
Exactly. Moderate intensity to a healthy 30-year-old construction worker is a vastly different physiological stress than moderate intensity to a 70-year-old patient who is actively undergoing toxic chemotherapy.
Obviously.
In exercise science, intensity has to be quantified to be safe. Are you prescribing a weight that is exactly 65% of the patient's 1 repetition maximum? Are you using a standardized rate of perceived exertion scale from 1 to 10? By omitting the calculation method, the prescription is left entirely to subjective interpretation.
Here's where it gets really interesting, though.
Yeah.
This brings up the irony of intervention fidelity. Fidelity measures how well a study actually stuck to its own protocol, right?
Yes.
The researchers looked at 2 key metrics here. Differentiation, which is how unique the experimental program is compared to standard everyday care, and dose, which is the strict measurement of whether patients actually completed the prescribed volume of exercise. The 12 studies reported differentiation 100% of the time. They perfectly explained how special and unique their interventions were. But the actual dose, 0%, Not a single study reported if the patients actually did the workouts as prescribed.
It's ridiculous.
It's like boasting to the entire culinary world about this incredible secret family recipe you've invented, but flat out refusing to write down the measurements of the ingredients.
If we connect this to the bigger picture, it fundamentally undermines the utility of the scientific trial. Intervention fidelity is how we distinguish between a failure in protocol and a failure in implementation.
Right.
Let's say a rural clinic attempts to implement one of these vague resistance programs, and after 10 weeks, the patients show absolutely no improvement in muscle mass or fatigue reduction. Why did it fail?
You wouldn't know.
Exactly. Was the fundamental exercise program poorly designed? Or did the patients only complete 40% of the prescribed sessions because they couldn't find transportation to the clinic? Without researchers reporting the exact dose delivered and any deviations from their original plan, we have no way of knowing if the medicine doesn't work or if the patient just didn't take it.
And that ambiguity is exactly where the academic failure translates into real-world fallout. We have to look at the concrete consequences for a clinic operating in a remote town.
Absolutely.
Why does a poorly reported methodology in a high-income Western academic journal pose an actual physical threat to a practitioner in the outback or, a remote town in the Rocky Mountains?
It really comes down to who is actually delivering the care. In an urban, heavily funded research setting, these interventions are usually overseen by highly specialized, oncology-trained clinical exercise physiologists.
Right, experts.
In fact, Rowe's review found that in nearly 92% of the interventions studied, the programs were delivered by certified cancer exercise trainers or specialists. If an urban specialist is handed a protocol that simply says moderate resistance, they possess the deep, specialized expertise to look at the patient's blood counts that morning and safely titrate the exact weight and volume on the fly.
They can essentially read between the lines.
Exactly. They can fill in the blank spaces in the instruction manual using their own extensive clinical background.
But out in the real world, rural health clinics don't usually have an oncology-specific exercise physiologist on staff. I mean, the person implementing this protocol might be a general physical therapist who handles everything from pediatric sports injuries to geriatric fall prevention across 3 different towns.
Yeah, they're wearing a lot of hats.
Or it might be a general practice nurse. They are trying to adapt these published protocols with a fraction of the resources, minimal specialized equipment, and 0 specialist supervision.
Exactly. When you hand an ambiguous, poorly defined protocol to a general practitioner who lacks oncology-specific training, the risk profile of the intervention changes entirely. A general physical therapist has to guess what the researchers meant by moderate.
And guessing is dangerous.
Very. If they guess too conservatively, they prescribe a dose that is too low to trigger biological adaptation, effectively wasting the patient's time and energy. But if they guess too aggressively, they risk prescribing a physically toxic dose, potentially causing severe muscle damage, extreme fatigue, or injury in a patient who might have to drive 2 hours just to reach the nearest emergency room.
Wow.
Furthermore, rural patients often face unique cultural and logistical barriers, like lower baseline health literacy, deep-seated fears about exercising during cancer treatment, and a lack of community support structures. An unsafe or ineffective exercise prescription only compounds those barriers.
So if you are a rural healthcare provider reading this journal tomorrow, or if you're an academic researcher planning the next trial, how do we fix this? How do we ensure the instruction manual is fully written?
Well, Rowe and his colleagues conclude with a very clear, actionable directive. The academic community has to mandate transparency. Researchers must utilize established, standardized reporting frameworks.
Like what kind of frameworks?
There are tools designed specifically to prevent this exact problem, like the Tidier checklist, that's the template for intervention, description, and replication, or the CERT template, which is specifically for exercise reporting.
Okay, so these tools already exist.
They do. These frameworks force researchers to meticulously document the FITT principles, the core physiological parameters of progression and overload, and the adherence to the prescribed dose. If journal word limits truly are an insurmountable barrier, then peer reviewers and editors must demand that this critical how-to data is included in the supplementary materials of the publication. The data has to exist somewhere accessible.
Yeah, it's entirely about closing the translation gap. It really doesn't matter if we discover a perfect, life-saving intervention in a pristine university lab if we cannot accurately translate that intervention to a patient standing in a rural community center.
And, looking at the sheer difficulty of translating these urban models to rural environments, it raises an even larger structural question.
Oh, what's that?
If urban clinical models rely so heavily on specialized equipment and hyper-specialized personnel that they cannot even be accurately written down, let alone safely implemented in under-resourced settings, perhaps the goal shouldn't just be about improving how we export urban protocols to the country.
Oh, I see. That shift makes complete logical sense. Instead of trying to force a highly complex, square urban peg into a round rural hole, we need to build a new model entirely. But how do we actually convince academic funding bodies to prioritize that kind of localized, ground-up research?
By using reviews exactly like this one to prove that the current export method is failing. The future of rural exercise oncology likely isn't about perfectly replicating city hospital programs. It lies in developing highly adaptable, community-driven interventions.
Built from scratch for those areas.
Exactly. We need models designed by rural communities, for rural communities, built from the very beginning to leverage the unique resources and social structures those towns actually possess, rather than constantly apologizing for the specialized resources they don't have.
Wow, that is a powerful takeaway. To wrap this up, the conclusion we can draw from the scoping review by Rowe and his team is incredibly clear. Resistance training is a potent, vital, non-pharmacological tool for rural cancer survivors. It builds necessary strength, combats severe treatment fatigue, and drastically improves quality of life.
It's an incredible tool.
But the current state of academic reporting simply lacks the scientific clarity and the granular practical detail required to safely apply that tool in the real world. The instruction manual is still far too blank, and that is a massive disservice to the practitioners and patients who need it most.
Recognizing the exact nature of the missing information is really the only way we can begin to demand better science.
Absolutely. I highly encourage you to read the full article by Rowe, Hart, Carlino, and Murray in the Journal of Sports Science and Medicine. It's a fascinating look into the mechanics of scientific literature. If you pull up the study, you can actually see their visual flowchart, which maps exactly how they rigorously filtered down those initial 2,490 studies step by step until only 12 remained.
It's an incredible visual.
It really is an illuminating way to see how scoping reviews systematically evaluate the quality of our medical knowledge. Also, make sure you follow the channel and turn on notifications so you never miss another deep dive into the research that is quietly shaping our world.
Because at the end of the day, when you are handed a powerful medicine, you deserve to know exactly how to use it safely.
No more blank labels. We'll see you on the next deep dive.